I think we should.
Good afternoon, colleagues. On behalf of IIHMR Delhi and University of Pretoria in South Africa, we take the pleasure of welcoming you all to the webinar, Health for All, Diversity, Equity and Inclusion. I would first like to invite the Trustee Secretary of IIHMR, Dr. S.D. Gupta, to welcome our esteemed moderator and panelist.
Thank you, Ekta, for inviting me in this very important webinar on Health for All, Diversity, Equity and Inclusiveness. I'm really very happy with this, that we started talking of Health for All again. We started talking about this in 1978 or so, and over a period of time, new jargons took over and we forgot Health for All. So Health for All 2000 and thereafter what? I think primary health care, now it is realized, is the main solution. But it has its own issues and challenges. So the whole world is diverse. Diversity everywhere, whether this is age, sex, ethnicity, or special population groups, or now displaced populations, special populations up till now neglected, like transgender. All that, I think this is important now that we look into the diversity and start looking into the social determinants of health. This is the time. And these inequities are mainly due to social determinants. So this is a very welcome initiative that has been taken by the International Institute of Health Management Research, New Delhi, in collaboration with very eminent universities, University of Pretoria, South Africa, and University of Jaffna. So this will be, I believe this will be a very important initiative, and this is a very important milestone that we have in building partnership and collaboration with these universities working on this area. I'm really very happy. We were waiting for Dr. Devashish Basu. Yes. He could not join yet, and so we'll look for him. Today we will have speakers, or you can say panelists, and the discussions will be moderated by Ghanshyam Sethi. He's a health specialist at UNICEF Malawi, and he will be guiding us on how to strategically move towards health for all. With his extensive experience in this area, he should be able to guide and help us in giving a direction to this discussion. I'd like to welcome Dr. Munir Islam. I did not know his full name was Qazi Munir Islam. I knew him as Munir. So welcome, Dr. Munir, to this very important webinar, and good to connect to you again after several years. Good to see you. I hope you are enjoying good health and doing very well. We have with us Dr. Professor Suren from University of Jaffna. He will be speaking about the displaced families and diverse groups in his area, how they were looked at. And then we have Dr. Urvashi Bhura from University of Pretoria, who will be speaking. And then Air Commodore retired, Dr. Sanjay Sharma, focusing on a very new, important issue of transgender. The focus has to be, this important webinar is going to focus on how the communities and people everywhere can realize their full potential and explore opportunities for their healthiest living. healthiest life. There should not be any discrimination based on caste, creed, religion, geography, or any other reason for which people may be discriminated. So I think this is the time the healthcare has to be inclusive. The theme of universal health coverage, and then theme of sustainable development goal, especially sustainable development goal 10, that talks about reducing inequalities around the world among diverse groups. I think this is the time we look into and try to integrate our ideas of universal health coverage with primary health care and health for all. Good to start talking about health for all again, and how we can reduce inequities in various diverse groups, and our healthcare becomes inclusive. While we are talking about diversity and inequities, I think we need to really look at into new emerging issues, like what happened due to disturbances in Syria and Iraq and that part of the world. And a lot of migration took place. It's still taking place. A lot of people have lost their lives. And the host countries who gave them home are still struggling with settling them down and provide necessary amenities like food and shelter, and also health. Then we have war displacements, and currently we find is this Ukraine war, and there's a lot of displacement taking place from Ukraine to other countries. Then we also have witnessed COVID that almost not only increased inequities, social, political, and economic inequities, but also, I think, a new life and culture post-COVID. And the danger of COVID is still not there. So COVID has been in great measure, has been responsible for inequities, especially economic inequities. I believe today in this webinar, we are going to focus on how we can address the issues of diversity. While we are talking about health for all, we are going to talk how we are going to address the issues of equity in healthcare and for all, and inclusiveness. All sections of the society are included and they have access to healthcare. With this, I'll stop. It was not planned this longish kind of welcome note to all, but the whole idea was that what we need to really look at in future, and it gives me a great pleasure that we have started talking about health for all and primary health care again. I think that is the only way to improve health and reduce inequities in health of the people, whether the access to resources or health outcomes or whatsoever we should be able to. So our eminent speakers will be talking about many of such issues today, and I'm sure all those who are participating in this webinar will be benefited with their experience and knowledge, which they will share with us this afternoon. So welcome again all participants who have joined us in this webinar, and all guest speakers and panelists, and Dr. Ghanshyam as a moderator of this webinar. Thank you very much for joining us. Over to Ekta.
Thank you, Dr. S.D. Gupta. The passion that you demonstrate while talking about health equity is something which keeps us motivated. So we are very happy to hear about your commitment to promoting health equity. I would now like to invite Professor Devasis Basu. He is the director of the WHO Collaborating Center for Social Determinants of Health at the Department of Public Health Medicine at the University of Pretoria in South Africa. Sir, we have brought a range of participants joining from different countries, representing academia as well as the development partners and the NGO sector. Please welcome the participants. Over to you, Dr. Basu.
Go ahead, Dr. Basu.
Hi, good morning. Sorry, I didn't realize that I was talking to myself. Good morning, colleagues, and it's really a great pleasure to be in this meeting with everybody. And we are looking forward to the deliberations. And as we mentioned it, it is one of the very important topic, not only for the many countries we are representing, but globally. And you have seen recently some of the backslash we are getting in some of the countries, which is retrogressing on this topic. And I'm sure from this one we can learn from the different topics and the presenters. And we are hoping that it will actually shed the light on how can we proceed on this topic. So we cannot put it under the carpet, because this is a threshing issues that every country in the world is facing, whether you are rich or poor, whether you're in different continents. And more importantly, my colleague will talk about when we see the migrant population, the vulnerable population, when they move from one country to another, when they move from one province to another. And I think that becomes much more difficult to manage it if we are not sensitive about this topic. I saw that Dr. Bura from my university is here, who is going to talk about that more of a practical experience. We have seen this quite a lot of this problem during the COVID, because it was really a challenging process for us. And we are definitely going to listen to that. And at the end, let me come back when we finish all the presentations, so that we can share some of the ideas and wrapping it up. And it's really a great pleasure to Dr. Ekta for hosting this. And I know that a lot of effort went into this for hosting it, and I hope this will not be the last one we are hosting together. And it is a deliberation from the visit which University of Pretoria had in Delhi, and IIHMR kindly hosted our university, and we are really excited about it. We are still talking about it. How can we move this process forward? And thank you, and again, for this opportunity. Handing over back to you.
Thank you, Professor Basu. It was you who had germinated this idea of holding this webinar, where we can invite people to talk about health equity, especially on this occasion of World Health Day. So thank you for guiding us and leading us on this. We are very grateful. I would now like to invite our director, Professor Shutapa Niyogi from IIHMR Delhi, to brief us about the World Health Day and the relevance of health equity.
Thank you, Dr. Ekta. Good morning, good afternoon, good evening to all the dignitaries and participants who are joined us on this occasion of this World Health Day celebration. I'll just briefly tell you about the World Health Day theme. So World Health Day, as we all know, is a global health awareness day, which is celebrated every year on the 7th of April. It was in 1948 that WHO had held the first World Health Assembly, and thereafter it was decided that starting from 1950 onwards, every year, 7th of April would be celebrated as a World Health Day. So it not only marks the founding of WHO, but is also seen as an opportunity to draw the attention of all to the importance of global health. This year, as WHO is celebrating its 75th anniversary, it is an occasion for all of us to look back at the success of public health across the globe, as well as the learnings and knowledge that we have acquired to address even larger and bigger challenges. It is often said that the modern public health has developed with the advent of basic medical sciences, and this is very true. There is ample evidence to show that the reduction in child mortality in the developed countries due to infectious diseases happened much before the discovery of antibiotics and vaccines. And there are experts who find that 80% of the increase in life expectancy is attributable to public health interventions. So, and also it is suggested that improved primary health care services can save up to 60 million lives and can also increase the average life expectancy of the world. With this philosophy in mind, in 1978 at the Alma Ata conference, it was declared that all people everywhere must have the right to achieve the highest attainable level of health, and all nations must aspire to work towards health for all. This year, again, the theme of World Health Day is Health for All. So this is an opportunity for us to examine the spectrum of diversity, of inclusion, and of equity. Across the globe, we all know that there may be individuals who may miss out on the critical preventive healthcare interventions due to several political, social challenges, which may slow down our progress, and also that may actually hamper the attainment of our SDGs. So we are very happy to have experts with us who will be sharing their knowledge, their experience of promoting health equity in very challenging situations. So with this, I welcome you all to this very important webinar, and we look forward to a very enriching, stimulating, and enlightening discussion. Thank you, and over to you, Dr. Ekta.
Thank you, Professor Niyogi, for setting the tone for this webinar. It is indeed a critical day for us to renew our commitment to health equity. I would now like to invite our moderator, Dr. Ghanshyam Shetty. He is the health specialist at UNICEF in Malawi. He will be moderating today's webinar. Welcome, sir.
Thank you very much. Good morning, good afternoon, good evening, distinguished guest, participant, and everyone. Welcome to our session on health for all, diversity, equity, and inclusion. So what I will be doing in next 1 hour, I will be moderating this panel discussion. Before we start, this is the uniqueness of these virtual sessions. We would like to provide some general guidelines and housekeeping rules to ensure a smooth and a productive session for everyone. Firstly, to our speaker, as you know that you have been allotted 10 minutes for your presentation. I kindly request that you stick to this time limit to ensure that we have enough time for all the presentation, including the question and answer session. So I have requested Dr. Dikshant will be the timekeeper and will be, give an alert, gentle alert when they have 1 minute to left. So Dr. Dikshant, please do that. Second, to all the participants, if you have any question for our speaker, kindly take note of them during the presentation. During question answer session, you can raise your hand or you can post your question in the chat box. Our panel will respond to your question during the question answer session. So thank you very much for your attention and cooperation. Now let's begin our discussion. Today, as you know, we have the pleasure of hearing from 4 esteemed speakers who will share their expertise on key topics related to health equity, inclusiveness, and diversity. We are honored to have these 4 distinguished speakers with us today. Their presentation promised to be informative, insightful. So without further ado, let's welcome our first speaker, Dr. Urbisa Vora, and she is a specialist family physician with the University of Pretoria, South Africa. Currently, she serves as the clinical head of the community-oriented substance use program called COSU in Pretoria. She will be speaking on the healthcare needs of the homeless and how we can address the challenges faced by this vulnerable population to ensure that they have access to the care they need so. So over to you, Dr. Bora.
Thank you for the welcome. Just to confirm that you can see my screen.
It's clear.
Okay, thank you. Just a quick disclaimer, I am a bit under the weather, so you will excuse me if I need to pause for a second or two. Okay, so thank you for the warm welcome, and it's nice to be invited to this wonderful platform. I look forward to this talk as well as future engagements as well. So I will be discussing the healthcare needs of the homeless population. So if we look at homelessness, what we do know is that it's strongly associated with poor health. And the contribution directly to poor health is through physical factors such as exposure, lack of shelter, or systemic and lifestyle factors, as well as lower levels of personal safety. Homeless persons spend much of their time and effort in trying to meet their most basic needs, which is normally considered appropriate help-seeking behavior in the housed population is often a lower priority for those who are homeless. And so this results practically in homeless persons presenting late and with a more complicated illness. They also struggle with non-adherence to treatment or appointments and follow-ups. And that's simply because priorities are shifted when you are living on the street or when you do not have secure shelters. So if we look at the definition of homelessness, how do we know who is counted as a homeless person? And there was an adoption of a definition of street homelessness, which excluded people living in informal settlements or substandard housing. And so in October 2022, the Unit for Street Homelessness at the University of Pretoria and its partners attempted to count all the street homeless people living in the city of Tshwane. Tshwane is one of the capital cities of South Africa, and it counted the people who live on pavement, under bridges, in bushes or next to rivers, those who fall outside a viable social network of assistance, and those who are therefore unable to provide themselves with a shelter at any given time of space. And it also took into account people living in homeless shelters on a particular night. And so this resulted in a number of 4,177 homeless people in Tshwane, according to the above definition. And so the health challenges that are faced by the homeless population, homeless persons are at much higher risk of mental health disorders, which includes substance use disorder. They are more likely to have a physical disability and contract infectious diseases like HIV, TB, and hepatitis, as well as suffer from violence and injury. So if we look at mental health and homelessness, they are interdependent variables in that one can cause the other. Multiple factors can exacerbate mental illness in the homeless population, and this can be as a result of a traumatic experience, substance misuse, and even general medical conditions. So if we look at the factors that surround homelessness and mental illness, they all have an impact on each other and they are all linked. So it doesn't matter where you start. So for example, a lot of homeless persons will face stigma, and this is due to poor hygiene, a lack of family support, etc. But stigma is also perpetuated by healthcare workers. Poor hygiene can even lead to a person themselves feeling uncomfortable in seeking help. So a lot of homeless persons struggle with accessing healthcare facilities, and that's another reason for late presentations. And then it comes back to poor treatment adherence, and then lack of insight. Now, lack of insight is two ways. Health facilities as well as healthcare providers sometimes do not have the understanding of homeless persons, and that again leads to stigma. And as we mentioned earlier, it's not so much lack of insight, but a differing of priorities. So whereas a homed person might present early because of an illness, a homeless person might seek food and shelter as a more urgent necessity rather than a minor ailment. So published data from Tshwane in South Africa, published this year, looked at the prevalence of mental health symptoms amongst street homeless people living in Tshwane shelters during lockdown. During COVID, most countries went into a level 5 or a complete lockdown, and in Tshwane, all of the street homeless persons were moved into either permanent or temporary shelters. And one of the largest shelters housed over 1,000 people, and then they were split into smaller shelters. So what the study looked at is the mental health symptom prevalence amongst the shelter setting residents. And so the DSM-5 cross-cutting symptom measure was used. And in the study, we gained consent from 295 participants. And what we saw is that substance use was by far the largest, most prevalent mental health symptoms, accounting for 68% of the symptoms. And then there was a lot of anxiety, followed by personality dysfunction, as well as depression, and then sleep problems, excuse me, and sleep problems. Now, HIV in South Africa, it is still a large problem in sub-Saharan Africa, with 68% of people who live with HIV globally being in the sub-Saharan African region. In South Africa, we know that 8.5 million people are HIV positive, and thus does not account for those who are unknown. So that number is probably larger. And we also know that people who inject drugs are at increased risk of HIV, TB, and viral hepatitis. The HIV prevalence amongst people who inject drugs is 14%, but this is an older study from 2011, so it is likely to have increased since then. And worldwide, we know that the coverage of HIV prevention, treatment, and care services in people who inject drugs is generally quite low. And there's a lot of barriers to access for those with substance use disorder, those with mental health, those who are mental health care users, as well as other key populations. And then if you add the complexity of homelessness to this mix, it does make it quite a complex situation and one that is difficult to manage. So this is a very nice diagram from a study that was done in Delhi. It's a mixed method study that looked at the different barriers to access for those who are HIV positive and opioid dependent, accessing opioid substitution therapy. And although the study was conducted in India, there are a lot of similarities to the South African and Tswane experience. So if we look at individual level barriers to access in terms of opioid substitution therapy, they found a distance of the OST centers quite far with low coverage areas. And in terms of ART access, expenses for clients to travel, and they also have to consider money, how they would access food. So there are a lot of common factors that affect generally homeless people, I think, all over the world. So structural barriers would include stigma, as we mentioned. And then health system barriers, which would also include stigma, but also timing of ART centers, long waiting times, delays in medication initiation, timings of the public health system. So there are a lot of commonalities between this study and the Tswane or South African experience as well. Now, the community-oriented substance use program is a harm reduction. It's an outpatient harm reduction program that is run in Tswane. It is one of the very few harm reduction programs in South Africa, and it's funded by the municipality as well as other stakeholders. In Tswane, we have 16 outpatient sites, and the services offered include screening and brief interventions, medical examinations, counseling, opioid substitution therapy, needle syringe or needle exchange services, HIV testing and referral. We are not yet at a point where our facilities can initiate ARVs, but we have partnered with local health clinics as well as hospitals and other organizations in the communities that would make referral to facilities a lot more streamlined. Then there's TB screening and referral, psychosocial services, skills development programs, and outreach and street medicine. So each of our sites have a team of varying professionals. There is a family physician or medical doctor who oversees a few sites. We have clinical associates, which are mid-level clinicians, which provide the clinical care of the patients, social workers, community healthcare workers, and we also have peer educators. So peer educators are previous clients or active clients who have previously or are still currently substance users who have now improved their life circumstances and have gone through the program with us, and they are then in turn employed by the program to assist us in reaching the substance using population. It's very difficult for someone who's not a substance user to go out into community of substance users without them feeling threatened. So it really helps us in reaching this key population. So the challenges we do face are resources, because funding is limited and not guaranteed. This is not it is a municipality run program, but it is not, well, the program is not being as nationally accepted, so it's not part of our national guidelines as such. We still are buying methadone privately, which then increases the cost. Access to basic primary healthcare medications is limited for our street medicine initiatives. Hospitals also do not provide substitution therapy for withdrawal. Knowledge around harm reduction is very limited. Communication between facilities, especially in the tertiary levels of care, is sometimes challenging. And then just the general clinical care of the homeless is in itself a challenge. So our standard treatment guidelines and procedures are often inadequate and inappropriate for homeless persons, and therefore continuity of care is often difficult. So if we look at how we approach healthcare services, the concept of community-oriented primary care is our guiding principle. So this is an active partnership between healthcare providers and the healthcare user. It is designed to begin with the individual and families in their homes and their communities so that they can create opportunities to improve health, contain illness and disease, and change the system of health. Now, this is a general broad concept, but if you apply this to homelessness, then you can see where the challenges are, because often the home and the family that are the most important parts of the care plan are often do not exist or are absent. So a significant part of caring for the patient is therefore absent in the management or in COPC. So how do we approach healthcare services then? So street medicine, which I will discuss a little bit more, and then peers or community healthcare workers who are within the community of the homeless, within the community in which the homeless live, go a long way in establishing a rapport with the clients so that access can be achieved for healthcare workers. If we're setting up a care coordination system for the homeless persons, then you need to network and also participate in local structures for assistance. There's a large role for local organizations in providing healthcare.
Sorry to interrupt you. Can you please wind up in 2 minutes, please?
Yes,
Already
that's fine. That's fine. And developing communities of care. So it's very important to understand the context. And so when street medicine is approached, it's the provision of healthcare to the unsheltered homeless, and it's a coordinated effort between clinicians, peer educators, and community health workers. So we look at screening, identification of high-risk users and health issues, and also linkage to care. So when we're coordinating care, we have different players and different community levels or roles. So if we look at the hospital and primary healthcare institutes, and how do we reach the community to meet the individual in their community? So it's extremely important to work with interdisciplinary health teams, try and attempt some sort of housing structure, and also to get support from law enforcement, because very often homeless persons are also targeted in that way. These are my references. Thank you.
Thank you very much, Dr. Bora, for the insightful presentation. So, as I on the healthcare needs of the homeless, as I mentioned earlier, we'll have a summarization of session, all key 4 sessions and the key takeaway. So I will not spend much time on this. Let me invite our next speaker, Professor Soren. He is the Dean of Faculty of Medicine at the University of Jaffna, Sri Lanka. He is a highly accomplished medical professional with over 20 years of experiences in the field of health system, social determinants of health, aging, and palliative care. He will be speak on the vital subject of mental health care, need of the victim of conflict and displacement. His insights and expertise in this area will undoubtedly prove invaluable to all of us. Warm welcome to you, Professor. Over to you. I think you are speaking with your mic muted.
Okay. Can
Thank
you
you.
hear me now?
Yeah, it's clear.
Okay. Thank you so much for detailed introduction about my profile, and I'm not sure that I've done that amount of work, but then I'm here to humble to present. Thank you so much for the opportunity. And then I am expected to know then the health diversity, equity, and inclusiveness that talk about something related to mental health care needs of the victims of conflict in displacement. In fact, we all know the Sri Lanka underwent this 30 year of protracted civil war, and that has affected a lot of its development. And then in between, we got the tsunami, and then COVID, and now economic crisis. So it's affecting really that equity of the health of our population. Although the Sri Lankan health system is considered one of the cost-effective and efficient health system in the world, and then WHO most of the time is considered as a kind of a model for other countries to consider. So today my talk, I'm trying to cover these mental health issues in conflict, and also I want to provide some of these international audience to understand the health profile of Sri Lanka and our experience during the war, and what sort of things that we are doing when we want to maintain these all affected things to rebuild and to bring the equity of the healthcare service in the country. So we all know that the war can affect all this normal dynamic of the basic unit of the family, and then the society, country, and all. It affect the system, the governance, and all sort of things. Then global experiences showing. This diagram is clearly showing that how that at the individual level, and how the relationships and the community. So then we all seen this kind of a disruption. I'm fortunate to work with these families with this domestic violence, child abuse, and then sexual abuse, and all those kind of a thing. And that's one side. Another side, we have that has number of suicides, self-harm, and then the people with these mental health problems. So one time that Sri Lanka was the world top most country of suicide happening. So still that is the big problem in Sri Lanka, but that we don't have enough evidences. But when we compare to the war is mostly affected the north and east of Sri Lanka than the rest of the south. So still this suicide and mental health problems are very high in this community. So when you look at this health profile of Sri Lanka, is a small country, a small island, and then with the population of 22 million. And then the main issue is now our population is fast aging, and also this economically we are not grown. So our life expectancy at birth is 75, and the literacy also relatively very high. And so comparatively, our indicators, particularly maternal and child health, are still very good because that we have a very good primary healthcare network, that in the country that we have more than 1,000 hospitals to cover the primary health care to the tertiary care. And also we have a public health system, and we have public health midwife. Then the person is responsible for actually 2,500, 3,000 person. We have a one public health midwife per 2,500, 3,000 population. And also we have a medical officer to responsible for 42, 6,000 population. And also in the country, we have around 17,000 medical officers and 30,000 nurses. So comparatively, our workforce is relatively good. And also then the system is most efficient. You can see that the government expenditure only 3.5% GDP. With that, so able to, this coming from 56% from the government budget and 44% from the outer pocket of the people. And then the Sri Lanka is able to achieve about universal healthcare coverage, about 68%. But still there are issues and things. So this is the main reason, that's because then the war and the economic development is a thing. So I'm here presenting one of the research paper that we have done recently with the support of these CDC Atlanta, and then patients coming to the primary healthcare institutions in Northern Province. So we found these patients coming to the primary healthcare, majority of them are having some sort of a mental health problems. So then depression, anxiety, psychosis with the hypomania, and then PTSD. So then and all this with the somatoform disorders. So after this, and we have done some of these WHO IIHMR thing that translated in the local language in Tamil, and then we try to train all these primary healthcare workers, and it's really helped us to improve the mental health services. But this research publication is in pipeline, and we are planning to publish in few weeks. So more than that, and also we have done something is about how this public health expenditure and the primary healthcare institutions, how the people are getting the services. So we found that although that we say there's a we have a kind of a wider coverage, and at the point of service, we have a free health services. In spite of all this kind of a thing, still then patients are expected to pay some amount of money, which has increased more, and then the burden to the people at the moment after the crisis. So this is going to be the big challenge. Now this country is planning to develop some of these alternative health financing mechanism and then methods to improve the universal health coverage in the country. So after all these things, and we thought this model, we tried to develop in our university area. We call this community-oriented primary health care. So through this, our Department of Community and Family Medicine. So you can see these kind of all these sectors, the family, community, and then the schools, and we have a kind of a school health programs, and then the public health midwives, the MOH office. The MOH office is the medical officer of health, that as I mentioned earlier, the medical officer of health is responsible for 40 to 60,000 population, and then under him or her, there are public health inspectors and public health midwives. They go and work with the schools, then community centers, and also this with kind of a divisional secretary is a kind of a government administrative divisions. There they have kind of a family counselors, child counselors, and social workers, and so then they all work together with the community. And also in the community, we get health clubs in the schools, and also community has a mothers club. So all these community driven, and then we try to empower all these community people to work with the problem of mental health. Substance abuse is one of the emerging problem. And also we are getting a lot of people with aging, and then due to the war, most of the young people, either they died or they migrated. So then now that we have elders and those who need a lot of support, so then we try to develop kind of a community-oriented elderly care services. So this is a model we try to start to implement from 2012. So then our publication is actually, we have published a book in this related to the our work related to this. So what we are doing now at the moment, we are really working to replicate this model to other places. Then I said in the northern province, there are about 90 primary healthcare institutions to cover the 1.2 million population. So we are trying to replicate this model to other places with the support of the provincial government and the central government of Sri Lanka. So these are the things that we tried, and actually community to go and help the people. So the way forward, what we are trying to, we know that all we know these principles is actually the mental health and the well-being for all the people. So it could be only possible when we mobilize the community. So then the main challenge again, there are barriers, a lot of stigma, and then the cultural taboos and things. So we try to work with the young school children and also in the community to mobilize these people to talk about more about their health and then owning their health for the development. So when we look at this, we want more leadership and governance. So the leadership and governance actually from the local people, and also we are trying to develop in kind of things like developing healthy cities and healthy villages by mobilizing the local authorities and the district and divisional level government officials to work with the community. Then the main thing is our concept participation. So participation is the key because we are living in a very low resource setting and then the middle income country. So it's possible only that community to contribute. So volunteerism is a very important thing. So then there are so many models. Even in India also there are successful models. Like one of the model, I am well aware that in neighborhood network, provide palliative care services in the Kerala, state of Kerala, then they provide a lot of good services. So that kind of volunteerism, now that more communities, and also we are getting a lot of local communities, and then expected, particularly because of this conflict, that most of the people now outside the country and then working in various countries, particularly globally in the developed countries, and their contribution back to home, that is also bring to more participation and things. So, and also we try to develop how these quality of service, and we do a lot of research collaborations, and also we are incorporating most of these students, postgraduate, undergraduate students to work with the community. So then universities, academic institutions, and various other institutions are working in this kind of aspect. And then we do try to know that solve these fragile and conflict-affected situations to bring it back, that rebuilding phenomena, but that the COVID and then economic crisis also bring it new issues, but still that we are able to develop those facilities. So then these are the things, because my limited timeline I want to cover, it's not possible to cover everything. So I hope that I have covered as much as possible within the given time frame. So then I'm very happy to give any more information for the audience, and when they want to listen more about how that we are handling that and then how we are trying to bring it back all these issues of diversity, equity, and then inclusiveness in the community. Thank you again for the opportunity for and invited me as a kind of a resource person, and then it's a good to discuss and then take it up more work with you all. Thank you.
Thank you. Thank you very much, Professor Suren, for an excellent, insightful presentation and sticking to the time, and particularly focusing on mental health care needs of victims of conflict and displacement. You rightly highlighted the community engagement and participation is key for any successful public health intervention. Thank you very much once again. And now I would like to invite our third speaker to start his presentation, Professor Munir Islam. He is a globally recognized health system and public health specialist with extensive experiences in universal health coverage, including sexual and reproductive health, maternal health, and policy, health policy and economy. He has traveled extensively and visited more than 100 countries and provided the policy, strategy, and training support. And he formerly worked with Liverpool School of Tropical Medicine, UK, WHO, both in Thailand and Namibia. Now he will be speaking on the critical importance of diversity, equity, and inclusivity as global priorities in the quest for health for all. Please, Professor Islam, please unmute your mic and begin your presentation. Over to you.
Thank you very much. Good morning and good afternoon. Today, health has become saving lives and livelihood. And if we want to achieve universal health coverage or health for all, then diversity, inclusiveness, and equity become important. Whether you're black and white or brown, whether you're rich or poor, whether you live in urban area or rural area, whether you are male or female, whether you have different sexual orientation, whether you are a public servant or a private sector, or you are an NGOs, everybody needs to be part and in partnership for policy development, strategy formulation, implementation, evaluation and monitoring, and research. Health is no more the domain of medical professional anymore. We have to get out of this idea, because we need medical professional. We also need IT technicians, managers, politicians, community leaders, religious leaders. We need to have everybody included into the policies, implementation, research, and all areas. If we really want to achieve the SDG, Sustainable Development Goals, or health for all, or universal health and universal health coverage. Today, also health is not the domain of Ministry of Health. It's not the domain of Ministry of Health. We are talking about health in all policy. So other ministries needs to be included in when we are talking about health, saving lives and livelihood. Ministry of Education, Ministry of Finance, Ministry of Defense, Ministry of Agriculture, Ministry of Climate, Environment. Everybody needs to come together for developing the policies, developing the strategy, and implementing it together, because it's no more. Because we always say health is Ministry of Health. No, it's no more Ministry of Health. Today, also, we need to also look at that the health has become a wider perspective. Now, COVID has nakedly shown that the whole world was not really ready for combating or facing this big problem of pandemic. Even the richest country failed to address these issues. Because what really happened with the COVID, we had a top-down decision-making. Communities, individuals, different groups were not involved to saving lives from the disease or the virus and saving lives for livelihood. So they were not part of this. We are being dictated from the top. And so some epidemiologists or public health leaders, they recommended what needs to be done. Then politicians weighed it where they will fit in, and the politician decided what needs to be done, but not really taking into consideration of inclusiveness, not talking about diversity and also inequity. So the COVID has really shown the world why this has become so important. Now, if we look at Singapore, Singapore is one of the countries we can give a good example how they managed to tackle the COVID. However, say when the first and second person who got infected with COVID, they are Chinese, originally Chinese, but they're Singaporean. They never traveled outside, but they had a business where different business people used to frequent particularly from China. They got infected. And then the third and fourth, they also didn't travel anywhere. They were in Singapore. But then suddenly we saw that whole COVID became an epicenter among the migrant workers. The migrant workers, how they live, what are their access, because there are different people, coming from different cultures, different language barrier. So they were really affected because 85%, nearly 75 to 80% of the COVID sufferers are from the migrant worker. Yes, Singapore has done extremely well of vaccinating most of the migrant workers. However, in 2022, when Singapore was open for everybody, but it was not open for migrant workers. So there was the group, disadvantaged group. We need to also look how they can be included into the policy making and program implementations and monitoring what is going on. If you look at in the UK, what happened? The Asian community, particularly Bangladeshi and Pakistani families, had really suffered badly. Why? Because most of them lived in a small place or small house where father, mother, and the children, their father and their mother, and the father-in-law and mother-in-law all staying together. And then because of livelihood, some of those people had to go out because they are hand to mouth. They had to go out for work, for really taking care of essential services in the UK, but they were mostly affected. Also, if you look at in USA, mostly African-American population group are mostly affected because they did not have access to the testing or care services, and they were mostly affected. And then also COVID, we have seen that certain group of people, particularly people who has chronic disease, people who are elderly people, home care, they were really, the services which was provided was not really adequate, or we did not adequately address those issues. So there are different group of people who needed to be included to achieve the health services or achieve the equity or health for all. Now, COVID also shown that there are issues about vaccines and vaccination. Because in most of the developed countries, we had good program of vaccination, they needed vaccine. So what they have done, they have uniquely invested on the vaccines and hold the vaccines, where the developing country people did not have access to vaccine. And it's not only vaccine, but also vaccination program. If you look at, did they have the -70 or cold chain? No, they didn't have. So even they had the vaccine, they could not really do the vaccination program, the training program, the need for money. And so where in most of the Western countries, there are a lot of vaccines are being discarded and destroyed because they're hoarding it. They did not really share with the global community. That's become a big issue. So this is another thing what we have come, that it is a global village. That is not, if we want to achieve health for all, not health for all for one country or two countries or three countries, we have to be together inclusively, that how everybody can be part and parcel of the program for reaching the health for all. Today, also we are looking at, there is a shift of disease epidemiology. We are shifting from communicable disease to non-communicable disease. Now, and for the non-communicable disease, comes a diversity. There comes a different group of people suffering different way, because the social structure has broken down. People before the habit, food habit, their living habit is all being changed. Like we talked about migration, people are migrating from the village to the city for work and livelihood, and they're going back. So there are a different group of people who need different way, different approach. There is no one size fit for all. So we need to look at how we can be more inclusive, how there can be a diversity, how we can have the quality or equity of each and everybody, not for one services for one people and different services for different people. That cannot be. So we need to look at that one. Then come the research. And we know what is happening. What is the inclusiveness of research program in globally, what we are looking at? It's mostly research is carried out by rich known universities in the Western side, and also some in Asia and in Africa, but it's not equally distributed. The funding are getting to the most of these institutions, but the subjects for research is becoming the developing nations. They are not part. Look at say 2022. How many PhDs were there in the globally, and how many are from the global south, and how many from global north? So research is also becoming another issue. We need to be inclusive. I'm not talking about any particular disease or particular area. I'm talking about the global picture. For if you want to achieve health for all, we need to really look into the diversity, the inclusiveness, and equity. COVID has shown us we no more we can only the medical people, only the Ministry of Health, or particular people can really run, because everybody needs to be. How the community leaders, how the religious leaders, how the opinion setter can be part of these issues. Because they are not medical people, they should not be included, no. Because we talked about determinants of health. Determinants of health is not the issue of Ministry of Health, is everybody. So this is what I'm really trying to look at globally. We need to talk about policy, strategy, implementation and monitoring, and research. In all those areas, we need to look at how we can be more inclusive. But the good thing is that we are now today, we are really increasingly discussing about inclusiveness, diversity, and equity. So this is really good. And I'm really hopeful that we will go from just, it doesn't become a jargon, but it become an issue that we take it seriously and implement it. But lastly, I want to say it's not a criticism, it's just an observation, I would say, just to think. When I was the director in the headquarters in WHO, one of the directors, we had 35 plus directors and higher level people who are deciding and who are really determining what needs to be done in WHO and how we should be doing it. Out of this 35 plus, we are only 5 to 6 people from the South, from developing countries, as a director and a higher position. right? Today, the situation, I don't know what is the situation. Yes, we can talk about, we have an African, Dr. Todros is the what is this, our Director General, but who are his lieutenant? Where is the diversity? Where is the inclusiveness? And where is the equity? So we need to start from the top and then go down and make sure everybody is involved. Thank you. I really thank the group for organizing the meetings, creating the awareness, and making sure that we go from talking to walking to make sure everybody is involved. So thank you.
Thank you very much, Professor Islam, for sharing your knowledge, insight on diversity, equity, and inclusiveness as a global priorities. Rightly you said, appreciate your contribution to the discussion on health for all. Moving ahead, let me invite our fourth and the final speaker, Dr. Sanjay Sharma, who is the founding director and the CEO of the Association for Transgender Health in India, ATHI, a non-for-profit organization working towards providing holistic healthcare and society inclusiveness for the transgender community in India. Dr. Sharma is also a board member of the World Professional Association for Transgender Health. Dr. Sharma's work has been instrumental in promoting LGBT inclusive policies, providing a global perspective on the issue. Now over to you, Dr. Sharma.
Thank you so much. It's really a pleasure and a privilege to be given space among such eminent speakers who spoke before me. And my job has become very simple because of the wisdom that has been already shared by the eminent speakers. Yes, today I'm going to be talking about the LGBT inclusive policies and would try to give a global perspective. But before I do that, I would also like to correct this title to read LGBTQAI++. Because yes, as we become more progressive, as we start understanding the human beings, we start seeing more and more forms, more and more diversity, and hence we become ready to make space for them. And this is where I would like to shift to the viewpoint that instead of looking at the branches, looking at the various forms, let us go to the root. Let us look at gender, because gender is what is at the base of all these diverse forms of expression that human beings do. And today, I'm going to take you on to the global policy on gender. Before I do that, let me just dive back into, what is the current scene right now? Well, more than 77 countries have discriminatory laws which prevent one to express their true self, forcing people to live in closets, to wear masks when they come out. And the penalty for expressing your true self may be a death penalty in 5 countries. What has this done? Well, produced a loss of vibrant human resource, which is so vital for building a progressive society. When we started back in April 2003, with Brazil presenting this issue of acceptance for sexual orientation, and we moved forwards to December 2006, when we expanded this to include identities, gender identities, because we realized the fact that gender identity is at the root. It is developmentally what we need to do first. Because it is once I identify or I become comfortable with who I am, would I look to be with, who do I want to be with, which is more of an issue of orientation. And it took us a few more years till 17th June, when we put out the resolution to put out the LGBTQ positive policies. Not everybody would be in agreement, and that is again human nature. So we had countries which opposed this, and we had countries which were very strong proponents of having positive LGBTQAI policies. India was silent, but not inactive. While the world was announcing, we were developing the dialogue. We took this down to the root. We allowed voices to come up. And in 2014, we had the landmark judgment by the Supreme Court, which said that gender identity is something which one self-affirms. Went on to read down the Draconian laws, which criminalized same-sex relationships. We went even further to have an act by the parliament which recognized the rights of transgender people. And we had the Transgender Persons Protection of Rights Act, which was put in force. And mind you, we are probably one of the few countries in the world which has an act in place, an act which is pan-India. And in 2020, we went further to define rules as to how we are going to make sure that people own the identity that they want to express. We also went on to continue the work for legalizing same-sex relationships. And today in 2013, we are waiting for changes in the marriage laws where we would probably be legalizing marriage between same-sex partners. A lot of work has been going on silently. But why do we need to do this? Why do we need a gender rights framework? Well, it is no rocket science. We do need this to ensure that equal access of basic human rights are given. We address distribution of resources in an equitable fashion. We promote access to education, healthcare, and employment. We create laws and policies which protect us from discrimination, especially protect the gender minorities, and support the initiatives which challenge the harmful gender norms and stereotypes that are present locally, which affect us to perform globally. Yes, we do need this framework to create a safer and more inclusive world for everyone. Well, how do we go about doing this? There is a framework which the international community follows, and this is something which has been done, be it for civil rights, be it for racial discrimination, be it for economical and social rights, for rights for women, for prevention of atrocities. But surprisingly, we are still not there when it comes to gender rights. And today, when from this platform we start this dialogue, or in fact, it would be wrong to say start, but when we take this dialogue forwards, when we have eminent people who have spoken before, and so many more minds who will be thinking about how to get this thing effective, I would invite you to look at human beings who are existing among human bodies who are diverse. We go the proven way of getting what is happening in each corner of the world, taking the best that has happened over there to allow people to express their true selves, interact with each other. Put this together, see how it works, put out in our communities, make it, tailor it to the local space that you are going to be ensuring that diversity is accepted first and then given space to perform, and then do the follow-up. Share the research. Get onto this cycle of what has been effective for all other aspects of that affect human beings. And if we are going to be doing this, I'm sure we will be moving towards health for all. But today, I would like to add another viewpoint and say that health for all is not enough. We need to add happiness for all. And happiness for all combined with health for all is what will ensure well-being for all. That was very rightly brought out by all our speakers, that essentially well-being is what is important if we are going to be looking at a progressive society. And I invite you to participate in this. I don't have facts and figures to share with you, and I don't want to, because what is more important is for us to start listening, for us to start offering support of affirming, for us to voice, be the advocate for people who are not able to voice their concerns, and most importantly, to empower the diverse community, the people who have been marginalized, who have been ostracized, but are very much part and parcel of all of human beings who deserve to have the same rights and live with dignity. I have ended my presentation, and I would like to answer questions if there are any, or take this thing forwards as you may wish to. Thank you so much, and once again, let me end by saying my thanks, my heartfelt gratitude to the organizers for bringing this beautiful panel together and for allowing us to voice. Thank you.
Thank you very much, Dr. Sharma, and thank you very much for saving some time for our question answer session. And thank you all panelists. As I mentioned earlier from the very beginning, that we will have a few more minutes to summarize the key takeaways for our participant, and also will provide opportunity to the participant to ask question to the eminent panelist. Just to summarize, our first speaker, Dr. Vora, she highlighted the complex and multifaceted nature of the homelessness and its strong association with poor health outcome. They are closely related. So access to care and addressing the root cause of homelessness, such as investing in affordable housing, are crucial for improving the health of homeless individual. And this is what Dr. Vora, she highlighted. And the second speaker, Professor Suren, he actually tried to correlate the conflict and displacement, how that can lead to mental health disorders. And to address that, he shared the Sri Lanka's experiences of a multi-pronged approach that involves the primary healthcare provider, leadership and governance, quality of care, but last not the least about community engagement, involvement and empowerment is key and necessary to address the mental health needs of affected population. Our third speaker, the Professor Islam, he highlighted the equity aspects. He said, he highlighted that healthcare is everyone's business. It's not only the government, it should be a whole of government, whole of society action to manage health risks and reduces socio-economic impact, particularly on emergencies and disaster. he gave the example of COVID-19, how and highlighted the need for diversity, inclusion, equity in policy, strategy, program implementation, research, and the efforts should focus on addressing these disparities involving diverse community in the pandemic response. Thank you very much, Professor Islam, for providing. Dr. Sharma, you are rightly, this plus LGBT plus QA plus, this highlight that we need to see far, not only focusing on these groups. That is a area. Your global perspective on LGBT inclusive policies are important to consider for improving health equity and inclusion for marginalized population like these groups. This is very, very important. So this is in short the summary of what our panelists, eminent panelists, discuss and share their experiences. So now let me open up this session for a question answer session, providing the opportunity to the audience to engage with our panelists. Sorry, we have only 5 minutes left for this question answer, but however, if you can put the question on the chat, we'll try to address that. I saw some questions already. To I think Professor Islam, how do you answer hoarding versus equity and inclusiveness? And then the second question is to all, how do we compare universal health coverage versus health for all? Maybe let me request Professor Islam to answer the first question about hoarding versus equity and inclusiveness. Over to you.
As you know, for the COVID vaccine and vaccination, the global community like WHO, UNICEF, World Bank, and all came together and developed the COVAX, the delivery system. But unfortunately, they didn't have that amount of money, amount of vaccine contribution to this. And so that's why it could not really provide the needed vaccines and vaccination program and support to many countries. So for hoarding, and then what we have seen, some of those countries who are hoarding, they send their vaccines. For Nigeria, they send 1 million doses of Pfizer with 1 month, what is this called, expiry date. And they didn't have the cold chain. So they could not implement. They had the vaccine, but there is no vaccination program. And so they had to really destroy all those things. So what we really need to look at, have a global community sitting together and saying that how much vaccine we have, what are the needs for everybody, and how can we provide that support? Because this is today we are in a global village, not one, because the COVID in India, Bangladesh, and many countries didn't come walking; it came flying from different countries. And I say today the disease before disease is to spread 20 kilometers per hour, but today disease spread 850 kilometers per hour. So so we need to have an understanding that we are living in a global community and how this international like COVAX can be supported and so that everybody benefit from that, right? So that is one way we can look at the hoarding because it's not a West versus East or South versus North. It's everybody together. We need to come together. And universal health coverage and health for all, it's almost the same. When you talk about universal health, it's everybody's health. We need to look at how everybody's health need, every group's health need is provided through diversity, through inclusiveness, some equity, right? So it's the other name of health for all. I think it's just, and moreover, I think we need to also look at. There are a lot of issues we'll be hearing. One health, health in all policy. This is all together to achieve health for all.
Thank you. Just maybe, Professor Islam, you have the additional question of does the current global power system leave space for equity?
That's the wrong question. Whether it does or not, we have to make it happen. And that is the discussion we are having, right? Whether it is being have or not. So why we are having this discussion? It's being left out. So we need to start have advocacy, have pressure, to make sure that everybody is included. The question is not why it's not, it has to be. So that is the question we need to, and how we can do it.
Thank you very much. The first question about to another question is to Dr. Sharma. What is the main hesitancy and concern felt by diverse population to reach out the health system?
Thank you for that question. And see, the biggest barrier is of of your narrative not being accepted, of entering a space where you're going to be judged, and that itself creates multiple issues. Because if my narrative is not going to be believed, then why will I go there? You may have designed something, but if you are going to judge me for that, then I am not going to be part of this. And we have seen this happen with the systems that are designed without taking into account who is it designed for. And that is the first thing that becomes very important for policymakers to understand, that when you are designing a system, it has to be designed by a participation, an active participation of the person for whom you are going to design. And for that, you need to listen. You need to listen to the community. The second barrier is that nobody is listening. We are sitting in our own silos, comfortable silos, and designing something which we think is what the community needs. And hence we produce fantastic frameworks. And then we are surprised that they don't work. We have tick marked all boxes. I have consulted all the experts. I just forgot to consult the community. I have done research, which is done by people who think they are providing what the community wants. I just forgot to, look and tell the people what is the outcome of this research and how is it going to help them. And for that, have I designed my research with the community in mind and with the community as participants in this research? I talk across the globe. I try to take on practices which are foreign to my culture. And I try to cut, copy, paste onto a local issue. But if you are having a family in, let's say, Ladakh or Himachal, and you're going to be cut, copying, paste something which worked for a family in Trivandrum, or for that matter in Kochi, or in Tamil Nadu, where supposedly more work has been done, then it's going to fail. You need to understand that the community or the people who you want to design a system for, before we start talking about why they don't come and take this, that is the undertone of this question. But why are people accepting what I'm providing? Well, it's like being offered a dish which I don't like anyways. So I hope it answers the question and also highlights the barriers. And I will again underline the most important one. Believe the narrative, understand what the issues are, and start affirming, start providing care. Health, when we talk about it, needs to be more. It needs to be taken out of the clutches of hospitals and healthcare providers. And it needs to be owned by the social systems. We need to move towards well-being. And for that, the people who know the science should be making provisions in consultation with whom they want to deliver. Thank you so much for that question. And thank you for that.
Thank you very much. In fact, we have already reached 1.5 hours. It's already 12. Maybe what we'll do, the answers, if you can please answer through the chat. There are a few questions we may not have time to take. Just to conclude our session, thank you very much, all the panelists, and special thanks to the organizer, IIHMR Delhi and the University of Pretoria, for bringing together such a diverse group of experts. I've never seen, starting from homeless, somebody who is talking about homelessness, to LGBT and other groups of experts to discuss key topics related to health equity and inclusiveness. Your dedication to creating a space for those key conversation is greatly appreciated. Once again, thank you very much for giving me the opportunity, and my pleasure. Thank you. Over to you, the IIHMR team.
Thank you, Dr. Ghanshyam Shetty, for moderating this very interesting and very thought-provoking session today. It was such a pleasure to hear from the experts from various countries and various domains, very insightful and very educational for all of us. I would now like to invite Professor Basu from University of Pretoria to share the concluding remarks and show us the way forward.
Purvi, are you going to respond? Dr. Vora?
Professor Basu, we can hear you.
Yes, I thought that you were going to respond because Prof. Hugo is not joining us.
We were just looking for some concluding remarks and a vote of thanks.
Okay. So, thank you. I thought that Prof. Hugo was going to do the vote of thanks. Again, just to mention at the beginning that it was a big pleasure for us to be part of this series. And we really appreciate all the speakers that who kindly shared their experiences and their comments on this. On a personal note, I actually wanted to share this because I found this quite interesting of an experience what I have recently, even in traveling in the European countries, where when this issue is brought up, I found this fascinating that actually creating a separate clinic or health services actually is increase the stigmatization rather than decrease the stigmatization even in Europe. And which is really interesting for me because I thought that it would be great to have specific clinics or specific health services dedicated to this group of people. And but it seems we need to revisit the whole process. So whether we mainstream it or whether actually we organize the services in a way so that we can take a cater for the specific needs, I think that's a question that we need to deliver it in future. And my request to the organizer is that please, if we can do in that regard, Dr. Ekta. Secondly, let me use my clinical hat and talking about the clinical and biological issues around this patients, that when we say equity and equalities, many instances we have specific changes in the body, whether because of the hormonal changes or is the biological changes, the structural changes that also need to take care of that process. And without that, I think it is, obviously there are psychosocial issues, but there is also specific needs for this group of people. We don't know whether they're more vulnerable to the specific diseases like oncology, cancer patients, or endocrinology, or cardiac diseases, etc. We have no clue. And I think we need to look into that. Having said that, I think the points made by the previous speakers, and I think extremely valuable, and we really appreciate. And my last comment goes to Dr. Ekta, to yourself and Professor Nyogi for taking the lead and organizing something and organizing across the globe. I mean, so we really enjoyed that interactions and understanding some of the comments made by the people. I'm taking notes, and I think my suggestion would be as a way forward to put this into a document and share that as a policy brief that which we can then share it across, because I think this is not just a one country issues, because we are living now in a global village, whether we are in Malaysia, whether we are in Sri Lanka, whether we are in Africa or India. I think people travel, and then it creates major problems when we address that issues. I mean, what do you do when you are in an airport? Do you join which queue you join, for example? And I think those type of things are really pertinent issues. And Dr. Ekta, may I throw that challenge to you that you need to take that further and we can discuss it. Number one, take it further. And secondly, to put this deliberation into a policy brief, and then we can share it subject to approval of all the participants. And from our side, we like to thank everybody for their participation and taking time off, and wishing you good morning, good evening, good night to everybody. And thank you.
Thank you,
Over to you,
Professor
Dr.
Basu. Thank you, Professor Basu. We will definitely document this for a policy brief. It is very, very needed. And as you had mentioned that this is a global issue rather than an issue which is at a national level. So again, thank you, everyone. Sorry, we don't have much time left today, but we are definitely here to answer your questions. We will be sharing the email ID in the chat box. You can send your questions to us via email. We will send those out to our expert panelists, and we will definitely come back to you with the satisfactory answers and the other information that you are looking for. And with this, we conclude this webinar. Thank you so much for joining, and we will be hosting another one soon. Thank you, sir. Bye-bye.
Thank you. Thank you very much.
I'll request everyone to switch on their cameras.
Thank you.
We will click a photograph.
No, I'm talking about the tomorrow in the IIHMR. Oh, this is public மேல எடுத்துட்டாங்க.
Thank you, everybody. It was nice having you on today. Thank you so much.
Thank you.
Thank
so
you.
much.
Thank you very much. Bye-bye.
Thank you. Thank you.
Thank you so much, everybody.
Thank you. Bye.